Why don't you tell for the people that don't know you, tell us a little bit about yourself.
Okay, grew up in the North, went to school in the South, went to LSU Med School, did a surgery internship in Kentucky, did my anesthesia training in California, University of California, San Diego, stayed on for an extra year to become a cardiothoracic anesthesiologist.
Hmm.
Moved to Nashville, Tennessee. I was in private practice for 36 years, retired 8 years ago. And during that time, wrote a book called Saving Grace: What Patients Teach Their Doctors About Life, Death, and the Balance in Between. Even though I specialized in cardiac anesthesia, I also had my pain boards. Did a lot of pain medicine early in my career. Got onto TikTok about a year and a half ago, just because someone said, "Hey, you got to be on social media for anybody to know about your book." So I did it for that reason. But to my surprise, I do these reels that I find really interesting, subjects that I find interesting. And it's really been so meaningful to so many people. It's become meaningful to me. So it was a real surprise to me, but I've got really nice interactions with so many people on TikTok and Instagram.
One of the things that first attracted me to your videos was the fact that you're very real about everything. Like you, especially and you show it in your book, just how you actually felt whenever you were dealing with harder cases or some anomaly that you had never had to deal with before. So yeah, it's really interesting to hear from a doctor who's not afraid, like who's not going to sugarcoat things.
Well, in the book, I just tried to be honest with, so it's sort of me, warts and all. But I really ended up trying to write a book about patients more than about me. So
Right.
they're really focused on patients and, in fact, what they taught me.
What was one of the most valuable things that you learned from a patient?
Um, I think one of them was to have appropriate expectations. I have the chapter in our Romania mission trip where I've got a little girl and she's got a bunch of congenital abnormalities, and we fixed her club feet, and she was going to wake up and for the first time in years be able to stand, and she'd be able to walk but not very well, and she had a little flipper hand, something called syndactyly, so she'd never be like you and me. But as I awakened her from her anesthetic, she was crying, and I thought, well, gosh, she's hurting. I haven't given her enough pain medicine, and I kept asking her, Lydia, are you hurting? And she said, no, no. And I finally asked her, Lydia, why are you crying? And she looked up at me and she said, I'm normal. I'm normal. And for her, being able to stand was enough to be normal. And that really affected me profoundly.
Yeah.
And it just really set my own expectations. You know, what should I expect about next week, about next year? It really brought me down to earth. I think that's the thing that was so humbling about medicine. It really brings you down to earth.
You could tell you were super involved with the patient, and you can tell how much you cared, which a lot of people also don't care anymore. A lot of people say their doctors don't care about them, and they feel like they aren't heard whenever they're actually going into an appointment and they're expressing, hey, I have pain issues, or who knows, I have severe depression, and the doctors kind of just blow them off. So the fact that you accept that and want to solve their issues is awesome.
I see this big change happening in medicine. And I hate to generalize, but my generation, the generation that is retiring or has retired, is far different than the youngsters coming up now. There's such an emphasis on money and such an emphasis on lifestyle. I gave a talk to the Nashville Surgical Society 2 weeks ago, and I so connected with them about what I expressed in the book. And, these are crusty surgeons. They're pretty tough hombres. And I got done with the talk, and I got one question, and And then it broke up, and one of the surgeons came up to me and he said, I was going to ask a question, but I cried twice during the presentation.
Wow.
Because I was just talking about the things that in the book that were so meaningful to me, and they were so meaningful to all of them. We all shared this common principle that it was a privilege to take care of a patient. And I don't see a lot of that anymore nowadays.
I was about to say, I feel like a lot of times doctors aren't the way that they were 10, 15, 20, 30, 40 years ago.
Where do you feel like this disconnect is coming from? Because it's not just the medical field; it's kind of everywhere. Even hiring employees for my business or the job I work at, finding people that actually do care is non-existent almost. It's like 1 out of 10 you might have a decent.
I think most people go into medicine really caring. They want to help people, but then they get into this morass. And two of the things that I think have been really detrimental, first of them is this electronic medical record that separates physicians from their patients. It's so much documentation and filling out boxes. When I would go see my internist, he would sit there with an iPad, wouldn't look up, and just check boxes. And those boxes were mandated. So the electronic record has been a mess, frankly. And the other thing is that we're in this era of the corporatization of medicine, that it's big entities that have taken over. I always used to say there's 5 economic stools in medicine. There were physicians, hospitals, healthcare systems, insurance companies, pharmaceutical companies, and medical manufacturers. And those 5 stools kept the system going. And 30 years ago, people didn't really think about money that much. They didn't worry about it too much. Physicians knew they were going to make a good living, and they're really satisfied with their lives. But right now, over 75% of physicians are working for either a corporate entity or a healthcare system or a hospital. You're no longer kind of employed by the patient, and you have so little control over your life. You're working for this corporate entity. So now there's only 4 legs on that stool.
Right.
Those legs are all fiercely fighting over the dollars, and money has gotten to be so preeminent in medicine, and it is dwarfed, that care for the patient, that we're here for the patient.
How often do you think it happens, like where a patient doesn't get the proper care because, do doctors think, oh, this procedure is going to cost us in the hospital way more than this procedure, so we should do the cheaper version? Does that happen?
I think most physicians try to do the right thing. Now, I probably have a little bit of a skewed view in that when I go see a doctor, I know that doctor. I've probably worked with that doctor, or I've been sent by somebody that I know very well. And I know that as a physician, you get a little bit more white glove treatment. They might spend a little more time with me or my wife. So I get that I have a little privilege there. But the physicians that I know, and especially my generation, they're all just trying to do the right thing. But they're in this system that says, no, you only have 15 minutes for this patient. You have to see this number of patients in an hour. And frankly, medicine is so siloed. I don't know how people that are not in medicine get the care that they do.
So how common is that a thing where they go in and they're like, you're a patient, you go in, get your doctor's appointment or whatever, and it has to only be 15 minutes.
I think that's par for the course. If you're working for a large corporation, you have metrics that you have to pass, and you have to crank out a certain amount. And as an example of how hard it is for normal patients to get care, my wife, as you know, is a chronic pain patient. Yeah. She gets radio frequency denervation of her SI joints. And she had that a couple of years ago at Vanderbilt, and she didn't get much relief. Well, I knew that there's something called a cooled RF probe, and that's the probe you need to use for the SI joint. It's the best probe. So after she didn't get relief, I asked her pain doc, I said, did you use a cooled RF probe? And he said, no, we don't have that. And I said, well, it seems to me like I need to find somebody that's got it. And he said, yeah,
Right.
you probably do. And I was like, you're on your own. Well, I know enough people, and I knew some people in New Orleans, and I called the pain doc down there, and he said, oh yeah, they've got that over at Ochsner's. I'll get you set up. And so he got me set up. We took her to Ochsner's in New Orleans. She got the RF probe. She got 100% relief. Now, if I were not a physician with some medical sophistication and some contacts, if I were just an ordinary patient who didn't get that relief from the SI joint, that would be the end of the road.
What would you suggest to people who are obviously non-medical and are having struggles? Because like you can go to Google, you can do your research or whatever and try and figure out what the best procedure for you is, and then I guess search for a doctor by who can do the procedure. But like what if you just can't figure out what's wrong with you? What if you're having severe pain in your arm or something, and nobody has given you the time of day, you've gone to multiple doctors, and you think you know a couple things, but like the doctors will ignore you and say, oh no, I don't think it's that. That happens a lot whenever you kind of self-diagnose, which I understand why, because we aren't the doctors, but what do you do?
Well, I think it starts with having a good primary care physician, somebody that you really connect with, that understands that when Kyle comes to see them and he says, I'm going to describe what's happening with me, that he or she understands that, believes that, and then says, all right, we got to get you some help. And then rely on them to be able to refer you to the appropriate people. If they don't know the appropriate pain people to go to, I think you need to go to people that are board certified in pain. Hopefully they've got a little bit of gray hair, so they've got some experience. And beyond that, I don't know that patients have a whole lot of ability to, navigate the system to say, oh, this one would be better than that one.
Do you feel like a lot of doctors are scared to prescribe narcotics?
First of all, most physicians are not skilled in prescribing opioids in terms of I'm able to titrate this with confidence, skilled in being able to say, well, this dose was not enough, and I'm comfortable elevating that dose. I think there's that side of it, and I think the other side of it is that the anti-opioid movement has so overwhelmed medicine that there's this thought that limiting opioids is a good thing, so that must mean eliminating opioids is a great thing. And well, no, minimizing opioids probably is a good thing. If we can find non-opioid answers for patients, who wouldn't want that? But when you find that answer, then maybe you have to go to an opioid. But there's this, I think fueled pretty much by this overdose crisis that we have in America, the idea that it's almost a religion. We have to get people off and keep them off of opioids. So there's a huge amount of misinformation and then fear of either prescribing without the expertise or prescribing and worrying about what various, federal agencies are going to come down on you.
So can we talk a little bit about like how a physician would go about prescribing narcotics in general? So like you go in for let's say your arm's broken, whatever, and the doctor says, okay, you need pain medication. where does it start whenever it comes to like you get 30 milligrams instead of 40, and this is how long you're going to be on them? Is it all case by case, or what's the thought process in
Yeah, it's
that?
all case by case, but everybody is taught in medical school this sort of World Health Organization pyramid of treating pain. And the principle is you start with a non-opioid. And that would mean either a non-steroidal anti-inflammatory, which could be anything from ibuprofen. If you're in the hospital, you might get ketorolac. Other drugs that are non-opioid that would be working via another mechanism, and that would be acetaminophen, Tylenol. Mm-hmm. So you start with those. And if
Toradol, things like that.
Yeah.
Right?
And if those aren't sufficient, then you bump it up a little bit. And you say, okay, well, maybe we need a Percocet, and I'll start with a 5 milligram Percocet. And you just escalate as you need to. You see what the pathology is, and then you say, okay, let's see, I just fixed an inguinal hernia on Marie. She may well need some opioid pain medicine for a few days, but I know it's a hernia repair. It's only going to be a few days. So I will give her.
I still feel like a lot of doctors are still scared to even go there. I know people that have had surgeries and got nothing.
Well, and what I'm kind of hearing from that is if you look at every pain incident and kind of approach it with that, the second the patient comes in because, you know, the anti-inflammatory or whatever isn't doing enough for the pain, they come in and say, hey, I'm still in pain. And the doctors are responding with, you're drug seeking.
Right.
That kind of ruins everything. It puts a stopper there.
Yeah, and it's so unfortunate. And I think that's the key to having a good primary care doctor, that they could say, you know what, I've taken care of you for 10 years. I know you're not an opioid seeker. I know you are a pain relief seeker.
That's why I feel like it's so important. This is the thing, continuity of care. You need to have the same physician. You need to build that relationship. But it doesn't happen in this day and age. Why?
Yeah, it's very tough.
It is.
And part of it gets back to that, I've got to crank you through the system. You're going to see my nurse practitioner. And if you see me, it's only going to be for a moment. I think the people that have the luxury of really spending time with their doctor are the ones that can afford to see a concierge doctor.
Now, what exactly is that for people that might not know?
Yeah, a concierge doctor is a primary care physician who has made the choice to limit their practice and limit the number of patients that they see in their practice. I see a concierge internist. I see him not because I wanted to see a concierge doctor per se, but he's the guy I wanted to see, and he had made his practice concierge. And so what he does is he limits the number of patients he has to 600 per year, but he charges each of them a fee to be his patient.
Right.
So my wife and I both go to him, and so he is able to basically support his practice, support his nurses based upon the fees that his patients pay for the privilege to see him. And I understand, man, I've got a great privilege to be able to afford this and to go see him and, to spend 40 minutes with me. Unfortunately, that's not available to just about everybody.
Do insurances cover things like that? I'm sure in some instances they can, but for the most part, not, right?
Well, they'll cover for me, they'll cover a basic office visit. But my office, it's always coded. Mm-hmm. Is it a complex office visit? Is a simple complex, depending upon the amount of time that they spend with you and the complexity of your problem. And there's big coding books for this. But the whole issue with him is I'll spend as much time as you need. It hardly is what I'm going to be able to bill your insurance company for. And for me, they bill Medicare, and Medicare pays so poorly that whether he spends 5 minutes with me or 35 minutes with me, he's not going to get paid much for it, but he's really paid by that yearly fee.
How do we fix this for the average doctors that are just in those big corporate places? Because I'm sure some of them at least have voiced the fact that, hey, this is not effective. We can't properly treat people. I mean, is there a big expression about that, or is it kind of just they're doing their job and doing the best they can?
Yeah, I think two things happen. I think, first of all, most of them are unhappy. Mm-hmm. When you survey physicians nowadays, and you look at the amount of anxiety, the amount of depression, the amount of burnout, it's way over 50%. And then you ask, why do you feel that way? Well, the common things are that that electronic medical record separates me from my patient. I don't have the time or the tools to really take care of my patient. And one of those tools is the ability to spend whatever time you need with them. They're kind of trapped in a system where they know what they should be doing and they know what they want to be doing, but often they're unable to really do it the way, the way they know they should.
Is there any way to, because the corporate businesses for the most part only care about money and everything, is there any way that there could be a happy medium, even if we're just talking about time with patients? I don't know. I was trying to think of something that would kind of be something in between. Hey, you still have to churn out this many patients, but you can have like 20, 25, 30 minutes and get that proper care. I guess that would be staffing.
Yeah,
I feel like since COVID, things changed even worse. Mm-hmm. Why?
Well, I don't know if they're worse. I think they were bad before COVID. I think most physicians in primary care, they probably take a pragmatic view to this. If there's something that my nurse can do for you that I don't need to do for you, my nurse or my PA will do it.
Right.
If I've had surgery and I've got a post-op visit, the PA is probably going to see me. Mm-hmm. And I suspect that most of them try to be as efficient and as quick with every patient that they can, so that when the one comes along that really needs more time, they're able to spend time with it. I mean, I think most physicians just do the best they can to try to impart the care that they know that they should be giving, but it's so hard to do. Most physicians are really unhappy in their practices. You survey them and, what do they say about the future? Well, I'm going to try to retire early. I'd like to get out of clinical medicine. It's just an unhappy system that so many are in. I had dinner with, Dr. Joe Slaughter in my book, The Orthopedist. I hadn't seen Joe in 10 years. He moved to Austin, but I had dinner with him 2 weeks ago. And it was so good to see him. And I saw him and I said, "Hey, Dr. Slaughter." But I said, "Joe, how is it that you're retired? You're retired kind of young." And he said, "David, the administrative stuff, the paperwork, it was so overwhelming. I just couldn't put up with it anymore." And I thought, You're an orthopedist. You're a surgeon. You're in the operating room all the time. I had no idea with that aspect of medicine that he had to put up with. Mm-hmm. I think there's a lot that goes on behind the scenes that people don't really know about that physicians are having to do, and a lot of that is, getting that pre-certification. No, it's denied. Well, they get on the phone with the chief medical officer. Fight on your behalf. All sorts of clerical work. It's just overwhelming to people. My daughter is a child psychiatrist in California, and she says, "Dad, I'm up at 4:30 in the morning doing my charts, and then her day starts at 8." Well,
there's not enough time in the day.
Yeah, whoever thought a child psychiatrist would have to get up at 4:30 in the morning to do the paperwork?
Like with technology changing and you being in the operating room, That's even got to be a thing. Like you have to learn the new machines and different tools. It's constant, continuous education.
The amount of education that goes on over the course of your practice lifetime is just absolutely enormous.
Yeah.
But it's the sort of thing that you have to keep at week after week. You sort of can't get behind. The journals that I subscribe to, they would come once a month, and they might stack up a couple of months worth, but I never let them get beyond that without going through them. And then you learn new blocks, you learn new techniques. I learned transesophageal echocardiography. They didn't have that when I trained, so I had to learn that during my practice life. But that's just learning science. I think it's something I think physicians enjoy doing. It's a little bit onerous in that it takes time and money to do that, but any good physician is just going to do that as part of their practice.
How has the pay been? Because I have heard some people say that like doctors are not quite making what they used to, depending on their field too, I'm sure. But then that falls down to nurses and techs and everything. The pay isn't enough to always support their family anymore and provide. So is that having an effect, and is it kind of catching up or anything?
Over the last 23 years, physician pay has gone down almost 30% in inflation-adjusted dollars.
Right.
Now, physicians have always been really well paid, so you could say, well, they were overpaid 23 years ago. A lot of the practice is Medicare and Medicaid. In our anesthesia practice, it's 50% of it. Anesthesia reimbursement, as an example, last year for Medicare went down 2%. Well, we know what happened to inflation. It's slated to go down another 2% this year. There's a continual squeeze on physician providers, but the same squeeze is the technicians, the nurses, everybody is getting squeezed, the people that are providing, because if I can squeeze you, there's a little more for me. And that's just part of this whole money over patient care that I see in modern day medicine. So physician pay has gone down, but it's still, I think the average is $360,000 a year, which is a lot of money. And obviously, some of the specialties like orthopedic surgery and cardiology, most of those make far more than that.
So, and that's how much the doctors are generally making and everything. How is it with nurses and your lab techs and stuff like that? Are they also making adequate pay?
Everything is supply and demand. Since I was in Nashville, every single year there's a nursing shortage. And hospitals say, oh yeah, we're trying to fill that nursing shortage. Well, any hospital could fill it. They just pay more money and you'll have all the nurses you need. I think that they pay lip service to it. Yeah, they've got to get the absolute minimum number of nurses to run that hospital. And remember, they're the glue. They're the secret sauce of patient care in a hospital. But they don't pay any more than they have to.
For people that may not know, what's the difference between like what a doctor does, a nurse does, nurse aide, all of that stuff? Because I know there are a million different things, but what's the gist of that?
Well, I think if you start at the top, physicians are taught to diagnose and to treat. Mm-hmm. Nurses, I think, are taught to monitor, to recognize when something is not right, recognize when it is going wrong. They do very much of the administrative, the patient care work, whether it's give you your medicines on time or maybe change that bandage or whatever it might be. And then the most basic of the care will be done with a nurse's aide. And of course, we don't have many nurse's aides anymore. Sadly, what used to be done by nurse's aides, and that would be maybe a bed bath, turning you in bed because you can't turn yourself, getting you up into your chair. The nurses are often too overworked to be able to do that, although they try to do that. That would always be done by a nurse's aide. Well, most hospitals have done away with nurse's aide, and so that falls to the families.
I think the kids are being crazy, so Marie stepped out for a second. But yeah, and my mom she has been a nurse for the last, I don't know, 35-ish years at this point, kind of ranging in all different fields. And I know her biggest job, she worked with a lot of mentally handicapped adults and stuff like that. So it was a lot of the changing bedpans, cleaning them up, making sure medication was taken care of. And then she would have like a separate tech for when they had to actually like administer things. It was kind of weird. I remember the pay not being great either. Like no matter where she was, I think until recently, I feel like we were poor. Like we were broke, and she was working a lot of hours every week.
Yeah.
You want to talk a little bit about ketamine?
Sure. Ketamine is an anesthetic drug. It came out in the 70s as an emergency drug. It was a drug that we could put people to sleep with because it would hold your blood pressure up. You came in with a gunshot wound, you bled out, well, you'd go to sleep with ketamine. Yep. And then as you were asleep and we transfused you, then we could switch over to conventional agents. It had some side effects that were beneficial. One of them was analgesia, pain relief. But about 25 years ago, the psychiatrist stumbled onto the fact that with relatively low doses and a series of treatments, ketamine was really effective for treating major depression. Major depression treated orally with the usual SSRIs like Zoloft and Paxil and stuff, that's effective in about 60 to 70% of patients. Electroconvulsive therapy, ECT, that's effective in about 60 to 70% of patients. Well, they stumbled onto the fact that a lot of these patients who didn't respond to those therapies responded to ketamine. And they would give a series of 6 treatments, relatively low dose over a couple of weeks, and they found that 60 to 70% of them had their major depression relieved. And if they did, they would then get boosters over time, usually every month or maybe every 6 weeks. So I helped set up a ketamine clinic in Nashville, and we treated a lot of patients with major depression that had failed other therapies. But over time, it's been studied and found that it's a pretty good treatment for PTSD. It's a decent treatment for chronic complex regional pain syndrome. And it's useful for some other things as well, like migraine headaches and so forth. So to me, it's really a wonder drug. And my wife gets ketamine every 3 weeks for depression and her CRPS. And it's been a lifesaver for her.
Whenever you started the whole ketamine clinic, was that very new in the grand scheme of things? Because I know whenever you do a lot of things that you're experimenting with the medication and other doctors aren't kind of using it in that way, you can kind of get a lot of flack, I guess. Were you guys one of the first, or? I
wish we had been, because, when I retired, I went to my group and said, look, guys, we need to be giving ketamine. It's so beneficial. And they just were, no, we don't do that. We go to the operating room. So I was actually taking my wife once a month to New Orleans. And she, and there was a ketamine clinic there, and I knew the anesthesiologist that was running it. And so he was really on the cutting edge. And he was the first in Louisiana. And then finally my group said, you know what? Maybe we should do that ketamine. And so then I, with another doctor, helped set it up in Nashville. And when we did set it up, by then, when I was taking her to New Orleans, there were a couple of other clinics, but I didn't think that they were well staffed. It's really important that you get the right person giving it.
Yeah.
And by the time we set it up, there were probably 10 other clinics, and I would have found 1 or 2 of them acceptable.
whenever you have things like PTSD and everything, how does that actually work? Does it just suppress, or do you feel like it cures?
With depression, it works on something called the glutamate pathway. There's this chemical pathway in the brain. With PTSD, they don't really know how it's helpful. They think it's based on neuroplasticity. Now, neuroplasticity just means we've got these neural networks, these communication between neurons in our brain. When I was in medical school, it was taught that that was fixed, that never changed. It couldn't be altered. Now we know that there's all of this plasticity, all of these changes that occur. And a good example of that is PTSD. These people that suffer from PTSD, they have enormous changes in their brain that if they're triggered and you're doing a functional MRI, you see changes in blood flow in their brains that aren't the same as yours. And ketamine in some way affects this neuroplasticity and allows lessening of that response to the triggering agent. As we're talking about this, let me just say for anybody with PTSD, MDMA is a psychedelic medication. It has passed phase 3 trials, which is the last clinical trial you need to then apply for FDA approval for your drug. And either late this year or next year, it is almost certain to be approved by the FDA for treating PTSD. And it'll be an absolute game changer, the most effective treatment for PTSD ever. It's coming.
So what does MDMA do that ketamine doesn't? I mean, the psychedelics have turned into a very big thing whenever it comes to depression, anxiety, PTSD, all of it. So what is the difference there?
MDMA probably works on that glutamate pathway as well. And it works on neuroplasticity, and it alters what they call a fear response. And that is, I'm triggered and now I'm totally freaked out with my PTSD. Well, that freak out kind of goes away, and it's like, oh yeah, oh, I see that. Yeah, I had a flashback to that IED going off or whatever it was, and I'm able to look at it kind of dispassionately without all those emotions. But as to the precise mechanism, you really can't say. Let me just say one thing about for PTSD people. Most of them know about this book, The Body Keeps the Score. It's a really, really famous book. It's an excellent book for anybody that has PTSD. Everybody I treated at our ketamine clinic with PTSD, everybody had that book. It's by a guy named Vanderkolk. And the drug company came to him because he's so famous and one of the world's experts and said, we want you to do the phase 3 trial for MDMA for PTSD so we can get our FDA approval. And he said, well, okay, but let's just do PTSD patients who have had a single event. That maybe they had an IED or a sexual encounter or something like that. Let's not do those with lifelong PTSD that had abusive childhoods because they are so difficult to treat. And the drug company said, no, we're going to do all comers. As a matter of fact, the majority of them were those that had lifelong PTSD. And now Vanderkolk says, man, I'm glad you insisted that we do that because it made a more difficult population to treat, and it makes the results of that phase 3 trial even more spectacular. 71% no longer fit the criteria for PTSD. Nothing comes anywhere near that. So this is absolutely revolutionary, game-changing treatment that's coming. MDMA along with some counseling sessions.
So basically it's, counseling sessions. That's what I was going to ask. The counseling sessions kind of help you come to grips with whatever happened, because a lot of people think too, when they think of PTSD, they think of war. This can happen. You can get PTSD from any traumatic event throughout your life, obviously. Yes, so yes. It basically just switches your brain to the point where you could still kind of have a flashback, but it doesn't trigger that fear response then.
Exactly. And when you think about PTSD, everybody has a little bit of PTSD in them. Think about some childhood event that was really traumatic to you, that you think back on from time to time, and it still bothers you. Well, that's a little baby PTSD. Now magnify it as something that, sort of dominates your life. Now that's major PTSD, but everybody has a little bit. They ought to be able to really sympathize with people that are suffering from really serious PTSD.
Is there still going to be like a sense of confusion, I guess, because you still in your mind think something is happening, but you can accept it a little bit better?
For the majority of these folks, these responders, they are able to remain cognitively very intact. Oh, that triggered me. Oh, yeah, I remember that IED going off. Yeah, that was a pretty bad experience. I'm glad I was able to move on from that, or whatever, So they are, they're so well that you can't even say, oh, let me try to diagnose your PTSD. Well, I can't diagnose you anymore because you're not suffering from those symptoms anymore. So it's just an absolute, I can't tell you when I've been more excited about a drug coming to the market in terms of the number of people it's going to help.
So how are other psychedelics coming into play whenever it comes to PTSD? Does MDMA have any like negative side effects to it, or is there anything to watch out for? Because it didn't work for everyone.
Yeah, MDMA is one of the few psychedelics that I didn't take when I was in college, so I have no personal experience with it. The other name for that is ecstasy, obviously. I don't know about. Presumably, it's got some unpleasant side effects because it is a psychedelic, and all of the psychedelics they can be a little terrifying when you take them, whether it's psilocybin or mescaline or LSD and so forth.
And are these lower milligram? Because like whenever you take shrooms, you can take a hero's dose and you're going to be seeing a lot of things, or you can take a microdose. Is that kind of how the MDMA is going also? It's like a microdose of the medication?
I can't tell you the dose. I don't know. I do know that in the clinical trial, I think they gave 15 sessions of psychotherapy and 3 administrations of MDMA. But psilocybin is now being studied for depression. There's an early study on that where they gave a single dose of psilocybin along with counseling, and the control group just got counseling, and twice the number of people who got the psilocybin had major relief of their major depression. There's no drug out there that a single drug administration will give you relief of depression. So that was a spectacular early trial. LSD, there's an LSD formulation by a company called Mind Medicine, and they call their formulation MM120. They gave a single dose of MM120 to patients versus control, and they had, I think, 48% had significant reduction in generalized anxiety. There's no drug out there that you can give a single dose and 3 months later say half of them are better. So this is really exciting what's coming down the road. And finally, the government and the FDA are loosening their restrictions on these psychedelics. They were legal in the 60s till about 1966, and then they were made illegal and put into Schedule 1 as a scheduled drug with, and Schedule 1 they say has high addiction potential and no medical benefit. Well, both those things are not true for the psychedelics.
Right.
But now the FDA is finally loosening, and even with, I think, the psilocybin, and this LSD, they have named them breakthrough therapy status. And when the FDA names a drug breakthrough therapy status, they reserve that for drugs that are treating a major medical problem for which there is no really good effective treatment. And so they have named that psilocybin and that LSD preparation breakthrough therapy status. So they are going to assist the drug companies in terms of, this is the kind of trial we'd like to see. No, don't go down that rabbit hole. Assist the drug companies to efficiently study it and hopefully bring it to market. And that's just a total 180 on the FDA.
I'm guessing this is going to be a little bit more regulated just because it is something that is so fresh and it was a Schedule 1. What's the difference between, like, you're getting this type of treatment in a hospital or doctor's office, special clinic, whatever, and then you have like ashwagandha retreats or ibogaine retreats? Ibogaine's a little different, but you have some of these week-long, 2-week-long psychedelic missions where you're out in the middle of nowhere and you're basically just given these drugs, and people say those are having a lot of very positive effects. Is that stuff all regulated kind of the same way?
I don't know about the retreats, but these are Schedule 1 drugs, so I'm sure these are not sanctioned in any way, and who knows where they're getting the drugs from.
Right.
I think it speaks to the power of these drugs to positively affect a lot of people. The fact that you can do it in a retreat and a lot of patients will benefit.
Right.
Presumably these are sort of safe environments. I think for all of these drugs, you really need, for psychedelics, they talk about set and setting being critical. How are you set? Are you looking forward to this? Are you not frightened about this? Where are you mentally and emotionally? And in what setting are you? Are you on a crowded subway where you feel threatened and now you're tripping on LSD? Or are you in a really safe environment where everything is optimal to you having this experience? So presumably that when these things, if and when they come to the market, you will be in the proper set and setting. You'll be in a therapist's office. They'll be there to guide you. If you become frightened, they're there to reassure you and so forth.
And I've heard a couple of people talk about it, and I can't remember who it was. It might have been Bert Kreischer, where he went on one of these retreats, and it has to be sanctioned, at least some of them. And I can't remember what he was using. I believe it was maybe ashwagandha. But he basically went on this retreat. You get rid of your phone. You aren't allowed to eat certain foods for a certain amount of time beforehand. While you're there, they literally give you a set menu, and you're kind of just in cabins, and you go through doing these nature walks and all types of stuff. And that is the whole goal of it. You aren't allowed to have your phone, have outside contact, nothing like that, because they want to make sure the setting and your body is as optimized as possible for the experience so that it actually does have a positive effect. Yeah. What's going on with these offshoots of tranq? Because basically what's happening is tranq became a scheduled drug. So since it is a scheduled drug now, it's illicit. You can't have it, on you. You'll get arrested. So they changed the formula of these drugs, and they did it with meth a lot, I think. But they changed the formula, and now it's affecting people a different way. In some cases, it's been stronger. It's been harder to reverse some of the effects. What is going on with all this?
Yeah, so tranq, remember, that's xylazine.
Mm-hmm.
It's been around since the 60s in Puerto Rico, really popular in that country for some reason. And then around 2010, it hits the East Coast. Mm-hmm. And since then, it's really been devastating, primarily on the East Coast, but it's gone throughout America. 30% of the overdose deaths in Philadelphia have this xylazine tranq on board. In 2022, of the illicit fentanyl powder that was seized by the FDA, 23% of it had tranq as mixed into it. And these dealers were putting this animal tranquilizer called xylazine into their, polypharmacy pills and then peddling it on the street. And they were doing that because the tranq was highly addicting and it wasn't illegal. You could buy it very easily on the internet from, literally thousands of sites. Well, now medetomidine is coming on the scene.
That's it.
Yeah, medetomidine, both of these drugs are something called alpha-2 agonists. And I used alpha-2 agonists in my anesthetic practice very often. Alpha-2 agonists have two primary actions. One is to lower blood pressure, and the other one is to sedate you. And depending upon the drug that you get, and this would be an FDA-approved drug, it might be a blood pressure pill that has sedation side effects. And when I use that, I use something called clonidine. And another alpha-2 agonist would have primary sedating effects, but it would have lowering the blood pressure side effect. And that was dexmedetomidine, something called Precedex. And I use that really often in my practice, and decent chance that you'll get it when you go into the hospital. Well, so dexmedetomidine, it's a form of medetomidine. When you have a compound, compounds often come in right-handed and left-handed versions. And by that I mean, here you've got a compound and you've got some atoms. And this would be the right-handed version. And if you have a mirror image, that's the left-handed version.
Sure.
And so this is the dextro and the levo version. So the dextro version of medetomidine is dexmedetomidine. That's the version, because that's the active version of medetomidine. So it's short as dexmedetomidine. That's what I use in my practice. Well, this medetomidine now is showing up on the streets. It's not, so what does it do? Well, tranq was nicknamed, or xylazine was nicknamed tranq because it made you so tranquil, and it made you, in fact, zombie-like. And I don't say that with any disrespect to the people that have been, their lives have been destroyed by that, but that was a good descriptive term of what people looked like when they had xylazine and fentanyl and all this other stuff on board. Well, medetomidine is 200 times more powerful than xylazine. So it'll go a long way. How would I use medetomidine or dexmedetomidine in my practice? Well, if you're in the ICU and you need to be on a ventilator, you have a breathing tube in, imagine how uncomfortable a breathing tube is. When you aspirate a little liquid, you cough like crazy. Well, now let me put a piece of plastic hose down into your windpipe. Imagine how easy it is to have that while you're awake. Well, when you're in the ICU, I could have that endotracheal tube in you, put you on a dexmedetomidine infusion, and you're tranquil. You can communicate with me. That tube doesn't bother you. So imagine if you take that drug, you throw in a little bit of illicit fentanyl, and you throw in a little methamphetamine and a few other things. Imagine what it's going to do to people. So this medetomidine is now appearing on the street. Nobody knows how prevalent it's going to be, but it is coming. And probably analogs of medetomidine and xylazine are coming, just the way these nitazines have showed up and all of those analogs. The bottom line being is, as Dr. EMZ, who I absolutely adore, as she has said, unless you have a pill that is from a pharmacist and from your doctor, don't you dare take it, because it may well kill you.
It's just, you can't anymore. And we had to have this conversation with the kids, and like I have Narcan on me at all times, pretty much. It's just everything is fake now. There's nothing, like the kids can't experiment. You know, you don't want them going and doing a whole bunch of stuff anyways, but I was young once. I remember, you know, hanging out with friends and somebody had something and whatever. You would take it, not a big deal. But now it's literally, you're likely to unalive if you take that pill. It's just, I don't know, it's a scary time to be a parent.
Oh, I can't imagine.
Yeah. So what would reversal be like, thinking in that vein, what would reversal be like for the medetomidine?
Yeah, unfortunately, there are no reversal agents. So you come upon somebody who is overdosed, you give Narcan to the point that they're breathing adequately.
Right.
You don't give more Narcan than that because you may put them into acute withdrawal. So you get them breathing normally. If they are still asleep and they're kind of unresponsive, there's a pretty good chance they've got xylazine or medetomidine on board. Then it's a matter of just supporting them medically. If they're deeply comatose, they go into the hospital, they may get intubated, go to the ICU, some of them die. But it's a matter really of waiting it out. I think you can dialyze that out of people, but you wouldn't ordinarily do that. You'd have to put a dialysis catheter in, and something that's going to wear off in a day or two anyway. But unfortunately, there's no antidote to these alpha-2 agonists.
That's crazy. Yeah, and that's kind of been the trend. Is I feel like Fent hit really bad. You know, obviously everybody was getting hooked on it. All of the pills that you were finding were Fent. And then once that started getting like chopped down on a little bit, all these things came out that just exploded that you cannot fix. We were already losing so many people to Fent. It was crazy. And now there's all this stuff. There's just nothing you can do about it. So it is a scary time.
Yeah, and these nitazines, I think they're going to be a big, big deal. Nitazines they're not illegal.
Right.
They have mu receptor effects, and there's these Frankenstein drugs, and the FDA has, or the DEA has scheduled some of these nitazines as Schedule 1, but then these analogs come up, and they pop up as soon as one's scheduled, a new one's made. Yeah. And they are appearing more and more. In 2022, in Knox County, Tennessee, that's eastern Tennessee, 10% of the overdose deaths had nitazines on board. They just came out of nowhere. So you're going to see them more and more. Now, fortunately, you can reverse a nitazine with Narcan, although you may need a really big dose.
Yeah, and that's kind of what it's been. It's there have been a few offshoots that I've heard are not being able to be reversed, but a lot of them you need a large dose. You will end up sending someone into precipitated withdrawal, very likely, but you can at least be saved. Do all of these two cause the same, you get sores on your skin, and is it all the same kind of side effects?
Nobody really knows for sure why you get the sores, but I think to me what makes sense is it certainly drops your blood pressure very low. When you drop the blood pressure very low, you don't have really good circulation to your skin. Right. Now you are in a position for hours at a time, and maybe you're lying on your shoulder, on your elbow for many, many hours because you've got that tranq on board, and you got that minimal blood flow to that area of your elbow, and then you end up with necrosis.
Right.
That would make sense to me in terms of the mechanism for that. And all of the alpha-2 agonists will do that.
That's one thing. I mean, I had enough trouble whenever I was just using the regular pills and everything, and fortunately was able to get off all that stuff. But I just can't even imagine. I help so many people now that are dealing with tranq and fent and just all these different things, and all they want is to get free, and it's literally they can't. Rehabs aren't able to help, nothing.
Yeah, let me just give a big shout out to you and Marie for what you do. I've got so much respect for the hearts that you have and the work that you do.
Thank you. We're trying to make a difference here and there, even if it's just a couple of people. I feel like it matters. But no, thank you for coming on. Love having you, like always. Hopefully next time we can figure it out and we can get a picture for you too. Do not forget, I have to grab it here, Saving Grace. This is Dr. Alfery's book. It is absolutely amazing. You can get it on Amazon, Kindle, and you can get audiobooks. And Doc, you do the whole reading yourself for the audiobook. I'm telling you, if you get the audiobook with his voice and everything, it is amazing. I loved it. I actually read part of the book and then went back and got the audiobook because Marie said it was so good. So yeah, it's just, I love what you're doing and appreciate everything that you've been doing to help the communities for pain and recovery and everything.